Hello and welcome. My name is Dr. Santhi Voora, and I will be moderating this session for you. I completed my nephrology and transplant nephrology training at the University of California, San Francisco, and I am a practicing transplant nephrologist at Keck Medical Center of the University of Southern California. It is my pleasure to introduce Dr. Joshua Zaritsky, who is a pediatric nephrologist at Phoenix Children's Hospital in Phoenix, Arizona. He received his medical degree and PhD from Stanford Medical School. He completed his pediatric residency at Denver Children's Hospital and fellowship in pediatric nephrology from UCLA School of Medicine. Dr. Zaritsky is board certified in pediatric and pediatric nephrology by the American Board of Pediatrics and specializes in a wide range of kidney disorders from kidney stones and nephrotic syndrome to rare disorders such as cystinosis and X-linked hypophosphatemia. Dr. Zaritsky has been named in top doctors listings across the country and is a fellow of the American Academy of Pediatrics, American Society of Nephrology, and the National Kidney Foundation. He is a cited author on 48 peer-reviewed articles, 9 book chapters, 5 reviews, and over 60 abstracts and 60 oral presentations at medical congresses. Dr. Zaritsky will be presenting on novel therapies for focal segmental glomerulosclerosis with emphasis on the role of lipid pheresis. As a reminder, CME credits are available for this webinar through Opus Medicus, who designates this activity for 1 AMA PRA Category 1 credit and 1 American Board of Internal Medicine MOC point. Welcome, Dr. Zaritsky.
Thank you very much. Thanks for the kind introduction. So let's get started. I'll just briefly go over the course objectives here, and we're hoping that at the end of this course, you'll have a better understanding of both the clinical attributes and the epidemiology of focal segmental glomerulosclerosis. In nephrology, we refer to this term as FSGS. I'll briefly review some of the poor results of available drug options to treat FSGS, and then we'll spend the majority of the time talking about lipid apheresis, its possible mechanism of action, and we'll touch upon its efficacy as a treatment for FSGS. And specifically in this course, we'll talk about its efficacy in the treatment of post-transplant recurrent FSGS. So this is an easy slide to start off with, because if you have anything to do with nephrology, you recognize that FSGS is probably one of the more dreaded diseases that we have to deal with, especially in pediatrics, I'll tell you that much. It's a descriptive disease. That is, for the last 150 years, we've been describing what we see under the microscope and throwing that label at probably 100 diseases that we just put together in one pot known as FSGS. Until recently, we really didn't understand even the basic pathophysiology of FSGS. Now we at least recognize that it's a disease of the podocytes. It's a podocytopathy. Unfortunately, we still lack diagnostic tools that can be used to guide treatment, and you'll see sometimes the cure is worse than the disease. Finally, there's this kind of now what phenomenon that we treat this disease empirically. We'll start with one treatment, move to another, move to another, move to another, and eventually you get to the end of the line and we have nothing left to offer patients. And on top of that, even if the patient goes to end-stage renal disease, we're still faced with the possibility that the disease is going to recur post-transplant. So this slide just shows you sort of the heterogeneity of FSGS, and we recognize it as a pathological lesion. So it's not surprising that there's several, I'll call, forms of FSGS. The one we're going to be talking about today is this one on the left, the idiopathic FSGS, which we really feel is an immunological attack on podocytes. Of course, there is a genetic or familiar form of FSGS, and now we're up to around maybe 50 genes that we recognize that once mutated, they can lead to FSGS. And they're, of course, all genes of the podocyte, and that's helped us to lead to the fact that FSGS is a podocytopathy. Occasionally, you'll see that the podocyte, the glomerulus will react to overfiltration or hyperfiltration with this same pattern of FSGS. And we typically see this in diabetes, reduced renal mass, obesity. We're not going to be talking about that form of FSGS today. And this form, this form here on the left-hand side, this idiopathic FSGS, sometimes we call it primary FSGS. And in fact, if we look in pediatrics, if we just looked at line items on the right-hand side, taken from the NAPRTIX database, you can see it's the single most common etiology of end-stage renal disease. And in pediatrics, we recognize it's a difficult FSGS is a difficult disease to treat and then deal with post-transplant because we see almost a 20 to 30% risk of recurrence of the disease. Finally, we've seen that the epidemiology of FSGS is changing, and it's changing for the worse. We've seen the frequency of FSGS in children increase dramatically over the last decade. We're really not so sure why. We recognize in African Americans, children will see a very high rate of it. We don't know if environmental factors are contributing to the underlying immunologic damage that happens in FSGS. One of the bright spots is we've identified several genetic mutations that lead to FSGS. And like I mentioned before, this has led to labeling FSGS as a podocytopathy. So what about current treatments? If we go to the KDIGO recommendations for steroid-resistant nephrotic syndrome, which eventually becomes FSGS, they're fairly standard. It starts with a course of steroids, which can be prolonged. We usually start an ACE or an ARB for renal protection. If that doesn't work, we then place the patient on a calcineurin inhibitor. And in pediatrics, I'll tell you, roughly about half of the patients end up on the left-hand side, that they show either a partial or complete remission, where you feel like you've gotten a little bit on top of the disease. However, in another 50% of the patients, we really can't get anywhere. And we really don't see remission in 6 weeks, 6 months. And you can see some of the options that the KDIGO recommends, and they're not good options. CellCept really does not have a role in the disease. Consider high-dose corticosteroids. Well, we've already tried a trial of steroids, so it's going back to the well again. And then finally, you'll see enroll in a randomized controlled trial. And up until recently, there just hasn't been a lot of trials to enroll your patients, and that's another bright spot that we're seeing. Before I get there, I just want to remind the audience that the treatment of FSGS is entirely empiric. So in nephrology, we like to make diagrams and explain stuff. And you can see here, it's not important that I go through, this entire diagram here, but the important thing to recognize is that the treatment's empiric. We do not have anything that tells us we should start with steroids or start with a calcineurin inhibitors. And so that makes it a very difficult disease to treat, where you don't know what's going to work. And so you try one treatment. If that doesn't work, you try another treatment. That doesn't work. And if that's not bad enough, if you look, the treatments are largely ineffective. As I mentioned, roughly 50% of patients will eventually end up responding to a treatment, most often a calcineurin inhibitor. But the other 50% of children and adults, for that point, really do not show any responsiveness. So you end up treating a large group of patients empirically with sometimes nephrotoxic medications without a result. And you cannot predict who's going to respond and who's not going to respond. So this slide I throw up just to remind me that we've seen a rapid evolution in the number of trials and agents out there. And so this slide is probably outdated by now. If we look, there's probably 8 ongoing trials looking at targeted treatments for FSGS. And in fact, it hasn't been approved for FSGS, but we do have sparsentan now, which is available to treat IgA nephropathy. But this is good news. This is good news that there are several new agents being studied to treat. Yes. Now, this just reminds me to show you the results of the sparsentan trials. In fact, this was data from the phase 2. Actually, the phase 3 trials have now been completed and published. And while the trial met its efficacy as far as reduction in proteinuria with sparsentan in FSGS, it did not meet its EGFR cutoffs. But the treatment is, we'll see what happens whether it gets approved for FSGS. It is available for IgA nephropathy. Now, this slide is here really to remind the audience that the plural of anecdote is not data. And I think what we've seen in FSGS in several cases is we've seen a treatment sort of rise through the ranks. And then when it goes to be tried by other groups, it's not successful. Abatacept was one of those drugs where it was published in New England. They had 5 patients who had responded to abatacept. But when it came to clinical practice, other people were not able to replicate the results. In fact, they were not able to show that B7-1 was actually present on podocytes where the original studies had. And even trying to get patients into a study ended up being very difficult. And you have to recognize, because it's a rare disease, treating FSGS enrolling patients in an FSGS trial can be very difficult to do. Now, looking at the etiology of FSGS, one of the things we recognize in a large portions of FSGS is we feel that there's a permeability factor in the patient that's produced that then goes and, I'll say, attacks the podocyte and causes the podocyte now to let albumin through. And this is what you would almost call a thought experiment that was actually carried out. So this is a published, I'll say, case report where on the left-hand side, they had a patient with a history of FSGS who they transplanted. That patient had immediate recurrence of disease. And you can see here immediately tremendous amounts of proteinuria in the red, and the GFR never improved. The kidney never really opened up. They tried treating the disease with plasmapheresis. They did a biopsy, and at day 14, sort of recognizing the futility of keeping the kidney in, they went to the IRB, asked for permission, and in fact, that kidney was taken out of the primary recipient and given to another recipient without a history of FSGS. And you can see what happened. The proteinuria immediately dropped off, and the kidney started working. And there's actually a case report in pediatrics where a patient was anuric, had recurrent FSGS, and was anuric for a full month. And then the kidney was taken out, given to adult, and the kidney worked. And this kind of argues to the fact that there's something intrinsic to the host. There's a permeability factor that's circulating, that as soon as you put that new kidney in, we see the production of proteinuria, unfortunately. And if we could only just identify that permeability factor, we could somehow remove it or prevent its production. And so, before I get there, this is sort of the basis of therapeutic plasma exchange, this idea that we could actually apherese out this solubility factor. And I throw this up here because I'll be talking about lipid apheresis. And a lot of times, TPE is considered the standard of care. When you look at the data for TPE, it's poor. There's no randomized controlled trials. There's just 4 controlled trials supporting what we do clinically with remission rates of about 50%. And you can see the guidelines that are produced by the ASFA show that basically recurrent disease gets a 1B recommendation. But notice, it does not get a similar recommendation for steroid-resistant in the native kidney. And lipid apheresis, although we've had success, has not moved up in ASFA's mind yet. It still receiving a 2C recommendation. And you'll see some of the data that I'm going to present and that we're hoping to actually move that up. So moving back to the search for the FSGS permeability factor, the Savin lab spent a lot of time looking for this factor. And they had a very nice assay looking at rat glomeruli perfused with serum from patients with FSGS, but never was able to identify what that solubility factor or permeability factor was. We had a brief dalliance, I'll say, with SUPAR, and there are still some groups that believe SUPAR is this permeability factor. Initial trials showed patients with FSGS had very elevated levels of SUPAR compared to other proteinuric diseases. When you looked at large databases, once again, indeed, patients with FSGS had high SUPAR levels. In fact, it was proposed that a cutoff of 3,000 would be diagnostic for FSGS. And in fact, when they looked at patients that responded to apheresis, they were able to lower SUPAR levels. However, once again, it's been very difficult to replicate this in other studies. And I think most nephrologists, not all, it's still an area of controversy, really believe SUPAR is a sensitive biomarker for CKD progression rather than that permeability factor. And this also shows you how the field has developed. I like showing this slide because, it's going to be hard to, identify, treat, remove the permeability factor without animal models. And we've really gotten there from a scientific standpoint in that groups are now able to produce in humanized mice a humanized model of FSGS where they're able to remove peripheral blood cells from patients with FSGS, put them in mice, and develop a mouse with FSGS that shows not only proteinuria, right, but also high levels of suPAR. So we are getting there scientifically. We're slowly getting there. So why are we talking about lipid apheresis today? And I'll first introduce the equipment here. Essentially, it's a form of therapeutic plasma exchange, but it's selective apheresis. And I'll show you what that means on the next slide here. This shows you how the machine works. So instead of centrifugal plasma separation, the machine uses a plasma filter here, which is able to separate out plasma. And it's a heparin-based system. So it looks very similar to a hemodialysis setup, except that the holes in the filter are large enough so that you actually remove plasma. That plasma is then run through a column and returned to the patient. So it's actually possible to perform this procedure on adult patients without exposing them to any plasma products. Their own plasma is rinsed through this column and then returned to the patient, as opposed to apheresis, where often you're replacing en masse 5% with 5% albumin or using some replacement with FFP. What's in the column? Well, it's in the column is cellulose beads with negatively charged dextran sulfate that was developed primarily to treat familial hyperlipidemia. That is, the negative charge attracts the positive lipoproteins in the blood and removes this. And this is, in fact, the FDA, one of the FDA approved uses of lipid apheresis, which we're not going to get into today, which treats familial hypercholesterolemia. It also carries another indication for removing lipoprotein little a. So why liposorber in FSGS? How did those two come together? Really, the data comes from Japan. And what they found is when they went to treat patients with FSGS who had very high lipid levels, they treated them for the high lipid levels, they found a certain proportion of patients went into remission. And based on some pediatric data, Kaneka, the manufacturer of the lipid apheresis machinery, brought one study to the FDA. And this is a Hattori study that was published all the way back almost 20 years ago now, where they did a retrospective study of 11 pediatric patients who had all been treated the same way. These pediatric patients all had biopsy-proven FSGS, and all were non-responsive to prednisone and the calcineurin inhibitor at the time, cyclosporin. And you can see the ages here, the onset to LDL therapy. Most of the patients, it was a mixture of primary and secondary steroid resistance, but most patients had been treated with methylprednisone and cyclosporin. And you can see large degrees of proteinuria. The protocol that was used was this protocol here, and I'll just keep this protocol in mind because this is the protocol that most people use. And essentially, it's an induction phase of 6 treatments, 2 treatments a week for the first 3 weeks, then a second course of 1 treatment a week for the next 6 weeks. And you'll notice that in the Hattori paper, they reintroduced steroids. So even though the patient was steroid non-responsive, they reintroduced it. And then they weaned the steroids off. And what was remarkable about this retrospective study is that 7 out of the 11 treatment-resistant patients went into remission, which is almost, unheard of, especially with this group of patients. And you can see everybody in the circle here showed a response, with several patients showing complete remission. Now, there were 4 out of the 11 that did not respond, which isn't totally unexpected. The study, and the very nice thing about the study is they actually had some long-term follow-up data from the patients who responded. And you can see in the squares here, those patients that didn't respond, they followed the natural history of a proteinuric patient, nephrotic range proteinuric patient. Most of the time, they'll go to end stage in a couple of years, and you can see all of them did. However, the patients that did respond, they showed, for the most part, a prolonged response. That is, they were able to stay in remission. So what predicted a response? Nothing. So once again, we have sort of an empiric therapy that you're going to try with a patient. They did note that patients who had a lower degree of tubular interstitial lesions did better, which makes sense for any disease you're treating. The selectivity of the proteinuria, something we really don't do these days, was the higher the selectivity of the proteinuria, the better the patient seemed to do. There was only one complication of a line infection. Several limitations of the study, small numbers of patients. You could make the argument that perhaps 7 out of 11 patients went into a spontaneous remission. I would highly doubt that. And then sort of complicating the analysis of the study is what role does the prednisone play? Why were these patients prednisone non-responsive and now all of a sudden they are? So, but with this data, Canica went to the FDA and asked for a humanitarian device exemption, which I'll talk about in a second. Anytime you present a treatment to a bunch of physicians or a bunch of providers, they want to know what is the mechanism. And here I'm going to throw a lot of stuff up on the wall and see what sticks for you. There's always a possibility that, for 2C, we're removing the vascular permeability factor, that somehow lipid apheresis is able to remove that vascular permeability. Maybe the vascular permeability factor is lipid bound, and by removing the lipids, you're able to do it. Maybe another possibility is that by removing lipoproteins, which compete for the entry of cyclosporin and tacrolimus into the cell, you get higher intracellular levels in the tissues where it needs to be, and therefore you get a better therapeutic response. Really not so sure. One of the things that I've become very interested in recently is this idea that we know there's a link between disordered lipids and CKD on sort of the macro scale, that hyperlipidemia, hypercholesterolemia is not good for your vascular endothelium. It's not good for hypertension, and that leads and worsens progressive renal disease. But specifically, one of the things I'll say, largely ignored in nephrotic syndrome is the disordered lipid metabolism. That is, we recognize these patients walk around with very high serum cholesterols, very high triglycerides. And it's not until recently that we've really spent some time and did some examinations. And this is one paper where they were able to sort of confirm, basically to confirm the molecular mechanism behind triglyceridemia and nephrotic syndrome and posit a hypothesis why lipid apheresis would work. And essentially the hypothesis is that, well, not the hypothesis, first for the significance of the hypertriglyceridemia, the path of why it happens, is that as albumin is lost, your free fatty acid levels go up, the unbound one. This then causes the increased levels of an enzyme, angiopoietin-like 4, which inhibits lipoprotein lipase. And it makes sense. If you have already high levels of unbound free fatty acids, you don't want to be chopping up more triglycerides. So this explains the molecular mechanism of hypertriglyceridemia. What they went on to in the paper is to say, hey, angiopoietin-like 4 expression in podocytes seems to be damaging to the podocytes. That, on top of the fact that the podocytes are trying to reabsorb or trying to prevent, the movement of albumin through, leads to this sort of maladaptive response. And the idea here is that if you have an injury to the podocyte, whatever that injury might be, that leads to albuminuria, hyperlipidemia, and this ratio of free fatty acids to albumin causes angiopoietin-like 4, and now you have a maladaptive response where that level of angiopoietin-like 4 remains high if the initial injury does not go away, and you have this vicious cycle where you're unable to really recover from the primary disease. And based on that, they said, hey, well, maybe lipid apheresis works by correcting the abnormal lipid levels, by removing that high free fatty acid, allowing a decrease in angiopoietin-like 4 expression, and sort of rescuing the podocyte. So in fact, where nephrotic syndrome represents a common endpoint of podocyte injury, and there could be 1,000 mechanisms, you could treat the disease basically by trying to correct the abnormal lipid metabolism. So I hope that makes sense. It's a hypothesis at this point, and the angiopoietin-like 4 story is more complicated than initially thought. There are, the group that first described it and looked at it found that they felt that angiopoietin-like 4 made by podocytes caused proteinuria, where those others made by peripheral tissues reduce proteinuria. And when you look across diseases, indeed, angiopoietin-like 4 levels in the urine at least go up significantly in FSGS compared to, for example, minimal change. But there's still considerable overlap. In animal models, they've been able to show that angiopoietin-like 4 expression overlaps that of other markers of the podocyte phenotype. And then you can see here that in animals where they had a model of injury that caused proteinuria, that indeed what first happened is they saw increased expression of angiopoietin-like 4 and then saw proteinuria pick up. And they were able to sort of mediate that urinary angiopoietin-like 4 by treating the animals with tacrolimus. In humans, there's really the only data we have is suggesting that, like in mice, angiopoietin-like 4 also is expressed by podocytes, but expressed in several different disease states here, not only FSGS. And the idea that could angiopoietin-like 4 be one of the molecular mediators of nephrotic syndrome will really have nothing. And in fact, there's only really one study looking at single nucleotide polymorphisms of angiopoietin-like 4, suggesting that patients who had a polymorphism of angiopoietin-like 4 that was associated with lower triglyceride levels had a protective effect. But we really don't have any cause and effect. I think that this hypothesis that somehow abnormal lipid metabolism leads to FSGS is one that still needs to be investigated. And I think this year we'll finally get to the point where we'll be doing some lipidomics on our patients and see, is there a particular fatty acid that's toxic to podocytes, for example, and by removing podocytes, we can let the podocytes recover. We still don't know. And so I'm still left with this idea, I really don't know what the etiology, the mechanism of action of lipid apheresis is. So let's go back and talk about how you would be able to use lipid apheresis in the country. Because it's a rare disease, the FDA, using the data from Japan, gave Canica a humanitarian device exemption on the device. What does that mean? It means basically that the device is safe, and they base that on the 30 years it's been used for lipid apheresis in patients with familial hypercholesterolemia, but efficacy unknown. And because of that, they mandated a post-approval trial. And you can see it's really FDA approved using a humanitarian device exemption when you have a patient who has EGFR over 45 and in which the standard treatment hasn't worked or hasn't been tolerated. However, any patient post-transplant is able to be treated under the HDE exemption. The current HDE post-approval trial is still going in both pediatrics and adults. The inclusion criteria make perfect sense. Basically, either most patients enter the trial because they haven't responded to any of the drugs, and the patients I'll be showing you they never responded to any drugs, or they just didn't tolerate treatment. There is also the way of getting into the trial is if you have a post-transplant recurrence of disease, you're allowed into the trial. Here's the protocol. They're still trying to enroll patients, get up to 35. I don't have a lot of data from the trial to show you. They use the same protocol, that Hattori protocol, basically 12 treatments over 9 weeks, this induction period of 6 treatments in the first 3 weeks, 2 treatments a week, and then 1 treatment a week afterwards. And I just want to show you how some of the preliminary data that I had when I was working at Nemours, there were 2 patients I ended up treating, and just using their weight as a surrogate outcome marker, you can see that both patients really lost fluid weight on treatment with lipid apheresis. And this was before I was using steroids in addition to lipid apheresis. The patient in blue actually stayed in remission, miraculously. The patient in red, unfortunately, as soon as we stopped the treatment, had immediate recurrence. And I felt to treat this patient symptomatically, we would put a fistula in and treat them at an outside facility, adult facility, with lipid apheresis maybe every 2 weeks. And while I was waiting for the fistula to heal, I said, let me repeat the lipid apheresis to make sure it wasn't a fluke. And this time I added steroids to the mix, and I have a little bit of a better end marker here, surrogate marker of albumin. This patient, the second lipid apheresis with the reintroduction of steroids, went into remission and stayed in remission. And this was sort of the opening to this idea of really going back to what the Japanese did, is combining the protocol with steroids. And in fact, what I ended up doing was using pulse Solumedrol in our post-transplant patients. And this is the first patient I treated like this. And I'll show you data from 7 other patients, I think 4 from 3 other sites, 1 in Cincinnati and 2 in England. We got together and published our data. Most patients underwent, once again, 2 sessions a week for the first 3 weeks, then 1 session a week for the next 6 weeks. And they received a pulse of 10 to 20 milligrams of Solumedrol, along with oral steroids during this phase. And you can see our first patient, who had been treated with Ritux, had been treated with plasmapheresis, went into remission and stayed in remission. And this is the data from the 7 other patients here. You can see most patients have been treated with a mixture of corticosteroids, rituximab, and plasmapheresis. Some of the patients had been on plasmapheresis for an incredibly long period of time, 18 months. 18 months in one case. And in the beginning, we weren't so sure how long to treat the patients, but eventually we agreed upon sort of a 9-week treatment course. 9-week treatment course. And I'm not going to show you each patient. This is published data. It's in pediatric nephrology. And like I said, 4 sites, Nemours, where I used to work, University Children's in Cincinnati, and then 2 sites in England. And you can show you that most of the patients did very well, and they were able to keep their graft. So finally, I mentioned in the beginning, the plural of anecdote is not data. One of the things we're really hoping to do is to do a controlled trial where we really go to show that lipid apheresis is an effective treatment for post-transplant. And we want to take advantage of one of the collaboratives that we're using. It's called the IROC collaborative that comes out of Cincinnati, which basically encompasses 15 pediatric transplant programs. And in fact, if you look, covers in 2021, covered 61% of all the transplants occurring in the United States. And you can see that the large group of hospitals involved in this collaborative. And what we'd like to do, I'm not sort of sure if we're ever going to get there, would be a controlled trial in which if a patient had recurrent disease, they would go on an initial treatment, and then they would be randomized to either the standard of care, which would be therapeutic plasma exchange, or a study arm, which would probably be LDL apheresis with possibly some TPE added in. And the nice thing about the study is if the patients did not respond, they would be able to cross over into the other arm. I don't know if this study is going to ever happen due to funding, and also the powering the study is very difficult. We might end up doing a smaller study, comparing results in centers that already are using LDL apheresis as their sort of primary treatment to compare it to TPE. I think it would be great to just be able to do this study because we could produce at least some hard data that would go to ASFA to say, hey, here's some randomized controlled data showing you TPE versus lipid apheresis. And I think we could also get some hard data to see how good is therapeutic plasma exchange by itself. You know, we have this idea about 50% effective. We've all had our patients who have responded, but we've also had patients who haven't responded. So I think that's, how did I do on time? I think I did okay. So just to summarize, there's many novel yet untested therapies for FSGS, and it's actually an exciting time to be in nephrology with several treatments coming down the line now for treating FSGS, whereas if we look 10 years ago, there was really nothing. There was nothing. For lipid apheresis, there is the ongoing post-approval trial that's going. It's about halfway through recruitment. As most FSGS trials, you know, has been very difficult to recruit patients. I myself and several other groups within IROC have had success in this rescue protocol in post-transplant patients. And actually, we were talking before I started the seminar. I'm now at Phoenix Children's, and we've actually had luck using this protocol in pre-transplant, that is in primary FSGS patients, treating the worst of the worst with this protocol trying to, get them into remission. And I'm hopeful, though I'm realistic in that we might not be able to get there, that we'll have a novel trial in the next couple of years comparing therapeutic plasma exchange to lipid apheresis within this IROC consortium. So I'll end there and take any questions. This is the way you can claim credits. CME and MOC credits are available online through Opus Medicus. This is where you go to in your browser. You'd look for course 262, click on exam evaluation and their certificate. My slides will be up there. They're for your reference. If you attended the webinar, you don't have to view the slides. For credit, you need to take the exam, fill out any evaluations, and then you'll be able to download a certificate. I think that's it. So open for questions.
Thank you, Dr. Zaritsky, for a very interesting and thought-provoking lecture on a very difficult to treat entity. I'd like to take this time to open up questions to the participants. Okay, well, I think I will start then. So,
Sure.
with regard to the heterogeneous response of FSGS patients to lipoprotein apheresis, as seen in the Hattori study and as well as others, are there any available tests which might predict a response? For example, checking triglyceride levels or free fatty acid levels or the angioprotein 4 that you discussed.
Yeah. I mean, you hit on the perfect, point is that once again, we have another empiric therapy. There's nothing that we can say is going to predict who's going to respond to therapy. We just don't have it. I can tell you we don't, because we don't let people on, we don't treat people with a GFR less than 45 because we feel they're too far gone, but we do not have that. And in fact, what we're hoping to do in the study is collect samples before treatment to see, is there something we can identify? Can we do lipidomics on these patients to say, hey, this is a patient that's going to respond? So we could actually skip the steroids, skip the calcineurin inhibitors, and go right to this treatment. And on the flip side, avoid treating people with an invasive therapy who we know are not going to respond, who we really understand are not going to respond. So I think that's that's one of the things we're still stuck at, that we have yet another empiric therapy. And unfortunately, because it's not a therapy that's very widely used or well known about, it's a therapy used at the very end. It's not a therapy that you're going to start off with. Now, it is an invasive therapy where obviously an extracorporeal therapy, something that is a lot harder to get up and running at your facility and introduces a lot more risk than the patient just taking a pill. But at the same time, we recognize FSGS is a progressive disease. The earlier the treatment, the better results we're going to get, most of us feel. So it would be nice to be able to say, hey, you're going to respond to therapy, and we're just not there yet. We're not there. I think probably what's going to happen is if we look at patients who respond, one of two things is we can then look at that subgroup and then work our way backwards mechanistically and say, this is the mechanism. And then with that mechanism say, this is why you responded. These are the patients we're going to treat. But it's been exceedingly difficult to get patients into the trial. And even the patients that I've treated, I've treated upwards of 40 patients now. It's difficult to know who's going to look at these samples. So it's just now that we're starting to biobank samples with the idea of doing lipidomics on them. That's the first preliminary step. But it's obviously an area ripe for research.
Yeah. Thank you. Very, very exciting time for nephrology.
Yeah.
Looks like we have a question here. So from one of the participants, I'll just read it from the chat. It is, why for this therapy filter is used versus a centrifuge?
It's a good question. Now, if we look at the two different treatments, we have TPE, which is the centrifugal way of separating out the plasma. think of it that way, is that we just remove the plasma and replace it. Here, what we're doing is actually filtering the plasma. So that's really the difference between the two. Now, at the end of the day, we might find that there's not a difference between therapeutic plasma exchange and lipid apheresis, selective. I'm biased with the fact that I believe lipid apheresis offers a better response rate and offers less side effects, because you don't have to, an adult patient, you're not exposing them to any plasma products. Whereas in TPE, you have to replace with 5% albumin. You have to sometimes use FFP. And you can see I've taken patients who have been on TPE, right, centrifugal-based filtration for 18 months, and then treated them, and they've responded to lipid apheresis. So there's something special about that selective apheresis, which seems to offer an advantage over standard, TPE. This idea, we're just going to apherese it out when in doubt. Here, we're being a little bit more selective. Why it would work, we still don't know. And we still don't know really why therapeutic plasma exchange would work. We have a supposition that we're removing the permeability factor, but we don't understand. And it also goes back to that idea that let's just say disordered lipid metabolism is something we've been ignoring for the large part. Let's say there is a component of disordered lipid metabolism contributing to the etiology of the disease. Obviously, lipid apheresis is able to really treat the abnormal lipid metabolism a lot more effectively than TPE, and that would suggest that's why that treatment's more effective.
Okay, we have another question from the audience. Are there different size filters for this therapy, similar to different dialyzer sizes in hemodialysis?
No, there's not. There's just one form of the filter. The extracorporeal, let me go back and just show you its next question. I'll show you there's basically two extracorporeal volumes for the filter. So it's designed for adults. So if we look at the blood side, the extracorporeal volume is somewhere about 160 cc's. That is the actual blood that's being taken out of the patient. The other side, the plasma side, and Jennifer can correct me, I think it's about another 340 mils of plasma, which the patient really doesn't see. So the FDA has allowed us to go down in the trial down to about 18 kilos, looking at the extracorporeal volume that's coming out of the patient. But I've had success going down to 13 kilos in some of the patients using the device off-label. So there's really only one filter size available, and you have to use heparin or something similar to like a gatroband. You can't use citrate with the filter.
Have you had any bleeding complications?
I haven't. I really haven't. And I think you can look, it does reduce fibrinogen to some extent. It's just not as extensive as TPE, because a lot of the coagulation products are not filtered out. And so much different than you would see someone else. So I anecdotally, I feel a little more comfortable using this pre-transplant as opposed to TPE. I worry a lot less. There are some, and I think one center did have I think I had a colleague in Nemours who had a patient who did have some problems bleeding after the treatment. They were for whatever reason, but I have not had any problems with bleeding with this therapy.
Yeah, well, that's great. Especially if considering, treatment right after a kidney biopsy or directly after surgery for me who treats post-transplant, recurrent FSGS, which is currently, right after surgery, as you know, can recur so quickly. So that is great to mitigate the risks of bleeding complications as compared to TPE. There's another question from the audience. Is there an age limit in using the device?
There's no age limit. The FDA, if you're going to use it under the HDA exemption, allows you to go down to 8 kilograms. It's more of a size limit based on the extracorporeal volume of the circuit. So let's just say, for whatever reason, you did not want to exceed 10% extracorporeal volume being, you'd say, well, maybe 16 kilos. If you're going to stick with HDE, it's 18 kilos. I have I've had success with going down to 13 kilos because these patients are hemodynamically stable. So that's sort of it's not really an age limit, more of a weight limit.
Another question I had is, given that free fatty acids are elevated in obesity and cause insulin resistance, is there a role for lipoprotein pheresis and FSGS related to hyperfiltration in the setting of obesity and diabetes?
Yeah, I mean, it's an excellent question. It's one of these things that we assume that, that FSGS is this pleiotropic disease, and that the reason we see FSGS and obesity is there's this overfiltration that happens of the glomerulus, and that leads to another scarring. And, where when the pathologist tells you, I think this is primary versus secondary FSGS, because this is what the EM looks like. I don't think anybody has an answer for that. Anybody has an answer for that right now. Clearly, there's something in my mind, right? And I don't have the data to back it up. There is a connection between disordered lipid metabolism and damage to the kidney. And so if you treat the disordered lipids, you'd expect to ameliorate the disease in the kidney. I just don't think we have that data. It's just, we just don't fully understand, what is the role of, we have these patients walking around with triglycerides of 800, cholesterols in the 500. Is that contributing to the disease? And we don't know. We don't know how to treat it. We don't know what to do. So I find it fascinating to think that, could it be that when someone finally figures this out, that the actual mechanism, the actual etiology was the disordered lipid metabolism, is something we've been ignoring for the last 50 years. That's what we should have been paying our attention to. And that lipid apheresis, by working, has said, this is the mechanism of action. So I don't have an answer, though. I'm willing to talk endlessly about, how this could be. And, at the last ASN, I was very excited when a couple of groups presented their data looking at disordered lipids and podocyte pathology. And so that was one of the groups I met with afterwards, saying, hey, we're going to have these samples. Can you do lipidomics before and after? Is there a toxic free fatty acid that we're able to remove versus lipid apheresis? Does that exist? And I don't know yet. I hope to have the answer sometime in my career, though, I can say.
All right, a few more questions. From the audience, has there been any allergic reaction to using filter for this therapy, similar to that which may occur in hemodialysis?
Yeah, so a very good question. One of the things you really have to watch out for is that the filter can cause a bradykinin-like reaction, most typically in patients treated with ACEs. So it's very important to make sure that the patient is off an ACE for at least a week. It's similar to TPE, where even centrifugal form TPE, they can have a bradykinin reaction. Same thing with lipid apheresis. If I avoid ACEs, I haven't had a lot of reactions to the filter. So.
Okay. And another question from the audience, is there a time frame follow-up after completion of this therapy to monitor for remission?
Another great question. And I haven't touched upon one thing, is that you could say, Dr. Zaritsky, why are you using steroids? The patient didn't respond to steroids and now they are. And for whatever reason, it seems to take the disease of FSGS and make it steroid responsive. So I've actually, in my hands and other people's hands, patients will have a relapse. 6 months down the line, they'll have a relapse. And, you're following the patients just based on their urine protein to creatinine ratios. It's usually, we have a good biomarker there, the urine protein creatinine ratio. Those patients remain steroid sensitive. So they have a relapse, you treat them with steroids and or Rituxan, you're able to put them into remission, which is another fascinating idea. Like, what is it? We always wonder when someone's primary steroid responsive and then becomes steroid resistant, why did that happen? And how is this treatment seemingly take someone who's steroid resistant and make them steroid sensitive? And it was just sort of kind of dumb luck, and looking back at the Japanese data, recognizing the importance that it's not lipid pheresis alone. but it's also the reintroduction of steroids, which really pushes patients into remission.
Next question is there body fluid removal with this treatment?
No, it's not like apheresis where you can kind of sometimes return, a little less fluid. It usually leaves the patient positive, depending on how much of that extracorporeal volume you're returning. So, for example, if you're just going to return the blood side, right, you're going to leave the patient positive. Technically, it would be 160, but you end up washing a little bit more through. So typically, we wash through with about another 220. So the patients do become positive with the treatment about 200 cc's. Now, if you wash out the whole circuit, which means taking the plasma side, you're going to leave the patient positive 500. I typically don't do that. I just wash out. All I care about is washing those red cells back to the patient.
What complications may occur during treatment, such as hypotension, etc.?
Yeah. Now, this is another thing where I have a little bit of a personal bias because obviously I do TPE and apheresis. I do all forms of apheresis. I do TPE and the selective form of apheresis. I personally feel a lot of the side effects we see in TPE, other than bradykinin reactions, are due to reactions to 5% albumin or probably FFP. Those are a lot of the side effects we see. Here we have a therapy where we're in adult patients, we're not exposing the patient to any plasma products, right? You prime the circuit with normal saline, wash the patient's plasma through and return it to the patient. So in my hands, anecdotally, and I think if you look through the data, even if you look through the data on patients who are treated for familial hyperlipidemia, another indication, these patients are treated every 2 weeks for their whole lives. And usually the treatment is very well tolerated. We typically don't see membrane reactions if the patient's not on an ACE, and we don't see some of the long-term reactions we see in patients who are on apheresis for extended periods of time, such as diarrhea or anemia. Typically, don't see that. So in my hands, I like obviously I'm biased towards lipid apheresis. In my hands, it's a treatment that I'm more willing to reach for with less side effects than standard TPE, and it's also a treatment that I'm willing to use immediately prior to the patient going to the OR.
Can citrate and heparin be used as an anticoagulant?
Yeah, so it's a heparin-based anticoagulation. For a patient who had HIT, I once used agatroban, similar to what you do in hemodialysis. It's not citrate approved, so I don't believe you can use citrate anticoagulation in this circuit. I don't know the exact reason. There is a reason why it's not a citrate approved membrane, so it's heparin based.
And another from the audience: what is the reason you don't rinse all plasma that's treated?
I think it's another, these patients that when you tend to be very salt responsive, and so the more you've already primed the circuit with saline, right? And so now you're dumping the saline into the patient. So at the end of the day, these patients are fluid overloaded, not intravascularly, but extravascularly. So I don't want to leave them with the extra fluid. So usually I only rinse back the red cell component. There's no reason why you can't rinse back the plasma side component. It's just that in my mind, I want to leave the patient as the least amount positive as possible. So if I can get by leaving them 220 cc's positive versus 500, that's what I want to go for.
What is the preferred access to be used for this therapy? Catheter, AV fistula, peripheral line, etc.
Yeah, I mean, I think this is one of these things that if you talk about it in pediatrics, so let me tell you. So for adults who are being treated for hyperlipidemia, a lot of times they can get by on their own vascular axis, meaning that they just have two veins that are used, which is great. I find in nephrotics and in pediatric patients who tend to have poor vascular, they need a catheter for that 9 weeks of therapy. Now, I've treated several adults who have come to me a priori with a fistula, and I've used their fistula. But you do need vascular access that's going to sustain a blood flow of about 30 cc's a minute. So usually that means if the patient doesn't have great veins, you're going to have to move to central axis. A fistula works just as well. It's just I find with the nephrotic patients, it's hard to find their veins. It's just not a. And I've even taken the teenage males and said, I think I can get by with IVF just using their veins, and I haven't had any success. The fistulas, of course, are wonderful, and in fact, the side effects the risks of undergoing therapy are largely just due to vascular access, clotting, infection. If they have a fistula, those risks really come off the table.
From the audience, what post-therapy education is given to the patient?
There really isn't any. There really isn't any. We tell patients to avoid the uses of ACE. Especially if you're a referral center, you have to make sure their nephrologist knows not to do an ACE just to avoid them. But it is a very well tolerated therapy, so there really isn't any specific instructions. Obviously, if they have vascular access, we have to make sure they take good care of that vascular access, don't get wet, call us if a fever. But there isn't anything significant that we need to do. It just seems to be a very well tolerated therapy.
Well, I don't see any other questions open at this time. Thank you so much, Dr. Zaritsky, for your
My
time and
pleasure.
presentation.
My pleasure.